Let me know if you can. Can everyone see?
Yes, yes,
Perfect. Okay, so let's start.
We can see.
Bismillahirrahmanirrahim. Okay, so thank you for inviting me. I'm going to talk today about the approach to headache in primary care. So for those that haven't met me before, my name is Mahibur Rahman. I'm a portfolio GP and a consultant in medical education. So portfolio GP means I'm a GP with different roles. So I am co-owner of my own GP practice, family practice clinic. I have held various other clinical roles. I work in community detox. And over the years, I've done lots of other clinical roles. Most of my time now is spent in medical education. So I run my own company, eMedica. We run courses to help doctors pass medical exams, to get into specialty training, to become GPs and pass MRCGP. I'm a fellow of the Royal College of General Practitioners, and I've written various books and articles to do with GP training and MRCGP. I used to be an examiner and invigilator for the General Medical Council for their PLAB exam, and our team at eMedic have now trained over 78,000 delegates. So today, what we're going to do is we're going to look at the approach to gathering the history, thinking about examination, getting the important data to work out what's going on for different key conditions that can present with the symptom of headache. Then the diagnosis or the specific condition that I want to look at in more depth is migraine, because it's a chronic condition that can cause lots of problems. It can cause significant difficulty in people in terms of living their everyday life, in terms of doing their work, and sometimes it can be quite difficult to manage. And then there'll be an interactive case that we'll do, and then finally we'll finish with a little quiz. And there'll be a dedicated section for question and answers at the end for anything that we haven't already covered. So let's start with data gathering. The first thing is that, very common, isn't it? Patients will come and they will present with, I've got a headache. And there's lots of things that can cause headache. It could be something as simple as a tension headache, self-limiting, just simple analgesia that they can get from the pharmacy, like paracetamol or ibuprofen, and that might be all that's needed. It could be something that is more chronic and can be more difficult to manage, like migraine, but it can also be a clue that there's something more serious going on. It can be a clue of a brain tumor, for example, or a stroke, or subarachnoid hemorrhage, something that needs an urgent admission to hospital. So how do we work out, is it something less serious? Is it something more serious? We need to start with the basics, and the basics is history. So we want to know things like the onset. Did it come on very suddenly? Did it come on gradually? Did they just notice it? How severe was it? Is it just like a background pain that's there and it just bothers them a little bit, but doesn't stop them doing their work, doesn't stop them focusing? Or is it the worst headache they've ever had, which is very common of how people describe subarachnoid hemorrhage, for example? When it comes, how long does it last? Does it last half an hour, 10, 15 minutes? Does it last hours to even days? Where is it? Is it both sides? Very typical of, for example, tension headache. Is it unilateral? Very typical of migraine. Is it at the back of the head? How often do they get the headaches? Is it something that bothers them once a month, a couple of times a year, every single week, nearly every day? Is there a certain pattern to it? Does it come always, for example, in the evening? Does it come at different times, but actually is related to what they might be doing? So there's certain precipitating factors. Do they always get it when they've not had enough sleep? Do they always get it when they eat chocolate? Do they always get it when they are a little bit stressed? What have they tried so far, and has that helped? Do they find, for example, if they lie in a dark room and lay still, that helps? Do they find that movement makes it worse? Do they find that, which painkillers do they try, and have they actually been beneficial? What are the characteristics of the pain? Is it dull? Is it aching? Is it sharp? Is it like an electric shock? And have they got any associated symptoms? So, for example, before the headache comes, did they get a funny sensation that something's coming, or any changes in, for example, their sense of smell, or did they have a feeling that they're going to be sick, but not actually vomit? Did they actually vomit? Did they find that light makes it worse? Did they find that even small sounds are irritating to them and make the headache worse? Have they got any autonomic or neurological features that might give you a clue to narrow down your differential? So those are some of the important things that you're going to ask in the history, because when someone says headache, there's 100 things it could be. And by looking at the answers to these things, you slowly narrow down your differential. So let's say now you've narrowed it down to a couple of things. What are some of the things that would be important as part of your examination? Type them in the chat or feel free to put your microphone on it and share. So you've taken a history of headache. What are the important things to think about in terms of examination as part of an assessment or consultation when someone presents with headache?
Sir, if you can repeat the questions.
Yeah, so you've taken a history of headache. What are some of the things that you want to examine in this patient that will help you confirm your diagnosis? So you've asked lots of questions, you've taken a history. We've talked about some of the things that you want to ask in your history. The other part of data gathering is examination, right? So what are the things you'd like to examine?
Eye examination.
Okay, excellent. What might be we looking for when we're doing an eye examination? What are the things that we specifically may be looking
In
for?
case of myopia or some, there is some headache.
Okay, yeah, that's great. Yeah, if someone, for example, like I'm short-sighted, if I don't wear my glasses and I'm straining a lot, that can cause a headache. Sometimes you see this in children as well, that maybe they don't know they need glasses yet, and they're straining a lot in class at school, and then they get a headache. And then once they have an eye test and get the right glasses for correcting their vision, their headache improves. So yeah, that's good. What else might we be looking at in terms of eye examination?
If the patient gave history of hypertension, check their blood pressure, some
Okay.
neurological examination,
Excellent. So
Scan of brain, CT scan.
if someone's blood pressure is raised, that can cause headaches. So that's excellent. Yeah. Neurological examination. Just to finish off the thing about eye examination. So one of the things that's also important as part of that is doing fundoscopy. If someone's got a headache, for example, and it's worse in the morning, and then they're vomiting in the mornings, what might you see on fundoscopy that will give you a clue that it could be a brain tumor? You might see papilledema, right? Evidence of raised pressure. Okay. Similarly, if someone's had raised blood pressure for a long time, you might pick up some hypertensive retinopathy. Okay. What other things would be important as part of your examination? Get involved. Oh, someone said something in the chat. Let's see.
Brain tumor also, CT scan in case of that.
Okay, yeah, great. What about if I had an older patient and they get headache more on one side? Maybe they're 65. Okay. What else would be a useful part of the examination? Think about what's one of the causes that we see in older patients that gives unilateral headache. They tell you when they comb their hair, that can sometimes make the pain worse. So they might have giant cell or temporal arteritis, so palpating the temporal arteries for older patients, especially over 50, that can be quite useful. And then to sort of complete your examination, examining the neck to look for things like muscular tenderness, stiffness, have they got limitation of movement, things like that can be useful. Okay, so you've done your history. Important to think about your examination. Okay, so blood pressure, we mentioned. If it's an older patient, palpating the temporal arteries. Neurological examination. If someone, for example, is at the early stages of having a stroke, that can present with headache. So you might pick things up on the neurological examination. Fundoscopy, so looking for retinal hemorrhage, looking for papilledema, and then examining. So now let's have a think about, in terms of how urgent is the condition and in terms of how we might manage it. I give you some descriptions of things, and then we'll see if we can put together what could be the diagnosis. So these are some of the conditions that are like the most urgent that can present with headache. They need to be admitted to hospital for a further assessment straight away, as in same day. So if someone had a history that the headache started after they'd banged their head or they'd been assaulted and there's been some kind of trauma, and especially if they've also got some degree of impaired consciousness, or you find in your neurological examination some kind of deficit, what could you be thinking about in terms of diagnosis? What would fit with those kinds of things in the history?
Low range, just a little range.
So could you repeat that? That wasn't clear, or type it in the chat. So this is how things like an epidural or subdural hematoma could present. And sometimes actually it might not happen straight away. So they might describe that they fell and banged their head a day or two ago. And then slowly, the blood is pooling, and then it causes compression. And then now they're having reduced level of consciousness, and the family members brought them in, for example. Okay, what about quite sudden onset neurological impairment? So they've got a headache, and then maybe they've got a weakness on one side of the body, came on quite quickly.
Sorry, Dr. Mahibur, please, may I have 1 minute? Myself, Dr. Mahibur speaking, one
Yes.
of the module coordinator. It's my
Hi.
pleasure to see you with us first. Just for convenience, I'm not sure that, can you talk something in Bangla if possible in course of your discussion? I find that some language barrier could be there if you continue in the English language with the participants. It's possible?
It's going to be challenging for me because I speak Sylheti. Most of the people here, they probably speak Shuddha.
Anyway, thank you. Give me the floor.
No problem. So yeah, sudden onset neurological impairment. So maybe they've got, weakness that came on. So they've got a headache, but then they also mentioned that, their left arm feels really weak, or as you're taking the history, maybe they've got some slurring of the speech. And when you do your cranial nerve assessment, you find that, maybe there's some things that are impaired there. What could fit with that in terms of headache? So things like a TIA or a stroke. Now, if they've got active neurological deficit now, until we prove otherwise, that's an emerging stroke. So they need to be seen and assessed straight away. What about if they had a very sudden onset pain, and within a few minutes, it got to a really severe, often they'll describe it as the worst headache ever. Or sometimes it's like someone smacking in the back of the head with a cricket bat. Really, really severe. And they may or may not have decreased consciousness. That could be subarachnoid. And until they've been imaged, we can't absolutely rule that out. Not everyone with subarachnoid has impaired consciousness until much later. Okay, other serious things that need to be seen same day. What about if they've got a fever, temperatures 39 point something, and they've got impaired consciousness? You find when you're looking at their neck movements that they can't touch their chin to their chest. It's very stiff. They find the light, when you're trying to do the fundoscopy, they find it really uncomfortable. The light makes it much worse. What could cause that? Could you type that into the chat, because that your audio didn't come across clearly. It might be my internet connection, it might be yours. Could you type it in the chat, please, if you don't mind? I'm really sorry, I can't hear that clearly. Could you use the chat to type it? Okay, I'll repeat the question in case it wasn't clear. So you've got a patient, they present with headache, and on examination, you find that they've got a high fever, temperature's 39 point something. They've also got an impaired level of consciousness. When you're examining, they can't touch their chin to their chest. They've got some stiffness of the neck, and you try to do fundoscopy, that makes the headache worse. You find the light very uncomfortable. They've got some photophobia. Great, well done, Dr. Anwar. That would fit with some kind of intracranial infection. So like meningitis or encephalitis can both present in this way, right? Okay. What about the patient with headache who's got very severe eye pain on one side only, and you see that the eye is red, the pupil is dilated and fixed, there's some haziness of the cornea, the visual acuity is significantly reduced to normal? What presents in that way?
Glaucoma.
Perfect. Yes, specifically acute angle closure glaucoma. Okay. And so again, they need to see an ophthalmologist straight away. Okay, so these are things where they need to be seen same day. What about things that they need to be seen fairly quickly in the hospital, but maybe not same day? So other serious secondary causes of headache. So if you got that older patient and they describe when they comb their hair that it hurts, or you actually palpate and there's tenderness over the temporal artery, we'll be thinking about temporal arteritis. So some of those patients might need steroids, for example. They might benefit from having a full workup. If they've got papilledema, they've got vomiting, especially early morning vomiting. If it's posture related, if the headache is waking them from sleep, what kinds of things might we be thinking about? The papilledema in this case is usually bilateral. Right, yes, a space-occupying lesion, or intracranial hypertension. So, very classically, malignant hypertension or brain tumor related. You get papilledema, early morning vomiting. That happens regularly, and then the pain will often wake them from sleep, because when they lie down, that makes it worse. What about you've got someone, they've got a vague headache, and maybe it's worse on days when they go to work. They have a day off each week, and they're at home. It's a little bit better on those days, and it's just been building up over some time. But now they've come to see you because they find that they can't concentrate, they're feeling sick all the time, but they've not actually been sick. Can you think of something that might present in that way, cause a headache, and where it could be in something to do with their workplace? Think about less common things that can, so carbon monoxide poisoning. So imagine someone that maybe works, they're working in a small workshop, and sometimes the shutters are closed, there isn't good ventilation, and the carbon monoxide is being built up because they're working with, some kind of gases and so on. That can present in that way with a headache, nausea, reduction in concentration. Then we've got the much more common cause of headache, which is the bulk of headaches and the ones that we manage in the community. So the very classical bilateral headache, it can affect the head predominantly, but sometimes they can say, oh, I also get some pains in my face, or my neck feels tight, or that the headache is described as a pressure on both sides. They may or may not have tenderness, and it could last anywhere from about half an hour. Sometimes they just say it's just there. I get it. It can last a couple of days, but it's not so bad that it stops them doing their day-to-day activities. They can still cook, they can still go to work, they can still, look after their family. That's the very typical presentation of tension headache. Finally, if you've got a unilateral headache, that they describe it as like a throbbing pain, usually associated, especially in adults, with either nausea or vomiting or both, and photophobia or phonophobia or both. This is very classical of migraine. Okay, and that's the one I want to look at in more detail, because it's a chronic condition. It can cause significant problems for patients in terms of managing their activities of daily living, impact on their work, can be significantly disabling. So if you've got a patient that you think might have migraine, what are the key things to think about when you're starting to take your history? You want to ask for them to describe the pain. As part of that, what side is it? Is it both sides? Is it front, back, all over? In adults, migraine is almost always unilateral. Children sometimes get bilateral migraine. How long does it last? What's the typical duration of a migraine? Type into the chat. So it can be anywhere from 4 or 5 hours to days, 2, 3 days sometimes. What's the nature of the pain? How intense is it? Do they have nausea, vomiting, photophobia, phonophobia? Again, in adults, it's almost always they'll have either nausea or vomiting or both. And almost always they'll have either photophobia or phonophobia. What makes it better? What makes it worse? So things like stress, sleep, lack of exercise, if they miss meals, sometimes having specific types of food. And if they can identify what food triggers it, that can be really useful because they can try to avoid it. Some people, for example, if they have cheese, they get it. Some people, if they have chocolate, they get it. Some people, if they have, a specific type of food, it will cause a problem. Then really, really important, what's the impact on it in terms of their day-to-day living, their work, their home life? Have they tried any medication so far? So to diagnose migraine without aura, the criteria are that they've got to have, remember the nature of migraine is a chronic disease. So they've got to have recurrent episodes. So generally in the UK, we wouldn't diagnose it until they've had at least 5 different episodes. And typically it will last anywhere from 4 hours to 3 days. In adults, it's almost always associated with either nausea or vomiting or both, and with photophobia or phonophobia or both. And then in adults, it's almost always unilateral. In children, it's often bilateral. It's usually pulsating. The severity is moderate to severe. It won't be like tension headache. Sometimes they'll describe it as mild. It doesn't really stop them doing things. And often just routine movements will make it worse, which is why when they get it, patients will often say that what makes it better, they just lie down for a bit, don't move, rest, and that helps in a dark room. And then migraine with aura, you have the typical symptoms of migraine, which we've just talked about, but before it starts, they'll have either visual or sensory symptoms, or sometimes issues with dysphasia, speech, and that comes on gradually and then settles within about an hour. So visual symptoms can be things like flickering lights, seeing spots, seeing lines, their vision becoming a bit reduced. Sensory symptoms, they might describe pins and needles, numbness before the headache comes. So aura comes before the headache. So how do we manage, what's the acute treatment of migraine? And there might be some differences here to what we use in the UK to what's used in Bangladesh, but I'll talk to you about the guidelines that we use here. Maybe you can educate me about some of the things that you might use. So someone's got very typical history of migraine. They're an adult. What would be a useful first line? So in the UK, generally, we would start a combination treatment with a triptan orally and either an NSAID or paracetamol. So maybe something like zolmitriptan, sumatriptan with ibuprofen or with paracetamol. So oral triptans, sumatriptans normally first line, 50 or 100 milligrams. We don't use ergotamines. We don't use opioids at all in the management of migraine anymore. We used to, like 20 years ago when I was starting out, use ergotamines like third line. Even if they're not being sick, giving an antiemetic can help to improve the management of the migraine. So if it's an adult, you can use things like metoclopramide, domperidone, prochlorperazine. Metoclopramide is not recommended in the elderly and in adolescents. Anyone know what's the common side effect that it causes in these age groups? Why we try to avoid it? Extrapyramidal symptoms. Yeah, excellent. And then anyone on triptans, if you give them triptans, we need to follow them up to see the response, how they're getting on with it. You don't just leave them to keep taking triptans, long term without any kind of follow-up. And then if the vomiting is so bad that they can't actually take the tablet and keep it down, then we can think about triptans that can be given either as a nasal spray, and in like 12 to 17-year-olds, actually nasal triptans we prefer over oral. It works better, the evidence is. Or you can also give subcutaneous, an injection of sumatriptan. Similarly, NSAIDs are available in non-oral routes. So diclofenac can be given as a suppository, PR, and things like domperidone as an antiemetic can be given non-orally. We can either give it as a suppository or as a buccal preparation. So just sort of, put it on the side of their mouth and it dissolves. Now, if a patient prefers to only have one treatment, you could try a triptan on its own. You could try an NSAID on its own. You could try high-dose aspirin in adults, okay? And you could also try paracetamol. Paracetamol on its own doesn't tend to be very effective. So let's move on to do an interactive case study now, okay?
How long should we give that treatment? How long?
Sorry, could you say that again?
How long should we give that treatment? That paracetamol treatment? How long?
Okay, so triptans, they generally would only use this when they get an attack. And so they take it as soon as the headache starts. And then if it's not improved, they can take another dose. But generally, it's for acute treatment. And once that episode is over, they're not going to take it regularly. They're going to then use it again the next time they get an attack. Okay, so let's do an interactive case study now. Some of you, when you're speaking, it's clear. Some of you, I'm finding that the audio is a little bit difficult to pick up. So you're welcome to try using the audio, but if not, use the chat to get involved in this case. I'd like everyone to try to get involved, okay? And what I might do is, for those that haven't got involved so far, I might actually just ask you to get involved. I might call you by name and ask you to answer or sort of get involved in it. So let's make a start. So I'll be the patient. So let's give you some background. I'm 44 years old. I'm known to have migraine. And you saw me before. You gave me some sumatriptan to take for acute attacks. Okay. So let's start. I'll be the patient. Okay. You're the doctor. What are some of the things that you want to ask me? I've come back again to see you. Just one second. Let me just stop the share for 1 minute so that you can see me. Okay, and I'll put it back on for you as a reminder. Okay, so that's the background. I'll be the patient, so I'll answer your questions for you. So feel free to ask me a question. You're the doctor. You can either ask me using your microphone or type it into the chat, and I'll give you the answer. And then we'll see if we can work out what might be going on. Would someone like to kick us off? Or should I pick someone? Should I just go from the top to the bottom? Dr. Barua, would you like to start? You can use the chat or use your microphone.
Sir, should I ask if you are patient and I am asking if you have any problem? That's it.
You're the doctor.
If you have any problem, so I will ask the pain subside or not, and
Okay, so just ask me then. I'll be the patient. Okay, so we're doing a role play. Hi, doctor.
whatever your pain.
So yeah, doctor, this headache, this tablet you've been giving me, I've been using it, and I've been using it a lot, but I'm still having headaches all the time, and it's stopping me going to work now. I need help.
So I don't know actually what to do now. So I'm talking with you. I don't know what should be talking right now, because I don't know about this kind of treatment.
Okay, no problem. Let's see if someone else can help us. Anyone else want to ask some questions? So I'm the patient. I've come back. This is the background. You know that I've got migraine. I've been taking sumatriptan, but I've come back because I'm using this sumatriptan a lot, and I'm still getting headaches. It's starting to affect my work. I tell you what, as perhaps people are finding it challenging to get involved. Let's talk it through. So what we already talked about, right, that we want to know about the history of the headache. So even though we know they've got migraine, sometimes someone can have a chronic condition like migraine, and if their headache's getting worse despite treatment, it could just be that we need to adjust the treatment, but sometimes it could be something else, right? Someone with migraine can also develop a brain tumor. So we still also need to get a history of the headache. So, has the characteristic changed? How severe is it? Does it go anywhere else? Where is it? How long does it last? Does this feel different to your normal migraine? Sometimes someone who has migraine without aura starts to develop an aura. Are there triggers? Are there things that make it worse? So if, for example, it's been getting worse, over what period? Let's say it's been getting worse the last 2 or 3 months. Has anything happened that's different? Maybe, for example, they've got increased stress at work. That can be a trigger for people. Is it affecting their mood? Having a chronic painful condition like migraine, it can lead to someone's mood to be significantly lower. So they might be at risk of depression. Okay. Are they, because of stress, not sleeping? Or if their work is more intense, they're doing longer hours, if they're not sleeping, that can set up a migraine. Have they had any recent changes in their diet? So again, sometimes someone's working away from home. They're working longer hours, so they're eating out at restaurants. They're not eating their normal home cooked food. And sometimes in restaurants, there might be things that we wouldn't normally have in our diet. And so that change could be an issue. Did they have any accidents? What if they were in a car accident? They could suddenly have had some kind of head and neck trauma that could be leading to this. Okay. Other things to think about. If someone's, say, they're using their triptan a lot, and they've got a known headache condition like migraine, it's important to think about medication overuse. So we want the specific details of how many days each month do you have a headache, not how many migraines, because one migraine might last 2 or 3 days. So someone might have, for example, 7 migraines, but each one lasts 2 to 3 days. So they might have 20 days a month when they actually got a really bad headache. How many tablets are they taking? And how many days are they having to use tablets each month? Are they using other over-the-counter medications, just things that they got from the pharmacy, from the shop? So what are the features of medication overuse headache? Someone who has a pre-existing headache condition, like migraine, very classically, they're having the headache for at least 15 days a month. And then overuse, for at least 3 months, they're using 10 days a month or more of triptans or opioids, which they shouldn't be using, but sometimes people just buy it. They get codeine from the pharmacy, for example, even though it's not good for migraine. Or 15 days a month for simple analgesics like paracetamol or NSAIDs. Okay. Now, it's important that we establish if it is medication overuse, because the management of that is different to how we manage, someone who's got migraine that, for example, is coming very frequently. So we talked about, again, what we'd like to examine, right? We examine the blood pressure, the pulse, fundoscopy, predominantly to rule out any of those serious things that need an admission. Okay. So let's say now this patient is actually only using the triptans. They're using it for 7 days a month. So it doesn't fulfill the criteria for medication overuse headache. But they're finding that they're losing a lot of days off work because it's that bad. They're getting a lot of headaches, coming every week. We don't find any serious examination findings that make us worry. So what we find is that what they've got is they're just someone who's getting an increased frequency of migraines that's not well controlled with those acute relievers. So we're thinking about maybe putting them on a prophylactic medication to prevent the migraines coming in the first place. So what are the options? What treatments can we use for the prophylaxis of migraine? So there's 3 treatments that we typically use in the UK, or 3 options. Any thoughts? Anyone get involved in the chat? Okay, so options are topiramate, so we use that 25 milligrams daily, or propranolol, a beta blocker, 80 milligrams daily, or amitriptyline, 25 milligrams given at night. Sometimes giving a vitamin B2 supplement can help. but that's on top, okay? They still use the sumatriptan for when they get the acute attack, but hopefully what this does is reduce the number of times that they have an attack. Now, we've got to be aware of a few things in terms of suitability. So, if you've got a patient, for example, who's got asthma, then a beta blocker might make that worse. So you'd avoid propranolol. If you've got a female patient who is planning to have a family soon, they're of childbearing age, topiramate can be teratogenic. So they can only be on that if they're on a very highly effective method of contraception. So, it'd be better if someone's trying to get pregnant or of childbearing age to avoid this unless there's no other choices. Amitriptyline would be okay, propranolol would be okay. And then in terms of thinking about the interpersonal aspects of this, explaining, like patients often will just say, look, I just need more of the triptan. Give me a higher strength. Just taking a higher dose of that won't help. Similarly, if someone needed treatment for medication overuse, you need to be sensitive about asking, are they using other things? Because if they feel like you're asking them in a way that you're suggesting that they're abusing the medication, people can get upset, okay? And sometimes patients might not want to go into details about what's causing them stress because it might be personal. They might be having stress because there's issues in their marriage, for example, and they're having a lot of arguments, and that tension is causing extra migraines, okay? So let's do a quiz to sort of start wrapping things up. So we're going to do a few exam style questions, all right? Is a way to revise some of the conditions that we've already talked about and hopefully to consolidate your knowledge. And these are quite challenging questions, so don't worry if you find them challenging. It's part of the learning process, okay? So I'll show you a question. I'll give you a minute and 15 seconds to look at it, to read it, to think about it. And then I'll see if I can, do we have a poll? Can't see that we've got a poll. I'll ask you to type your answer into the chat, okay? So here's the question. Have a look at that. I'll give you a minute and a bit, and then I'll ask you to put the answer into the chat. Okay. Let me know in the chat what do you think the answer is. So you can just type A, B, C, D, or E. Now, this is an example of what we call a two-step question. You can see the question's asking about management, but what you need to first think about is what do you think is the diagnosis? So feel free to type that as well in the chat. What do you think the diagnosis is? So a couple of big clues here that this headache started out of the blue and it came on very quickly, minutes. Severe and diffuse headache, and they vomited this morning. Cranial nerves normal. They've had a bit of stress. No neck stiffness, no history of headaches at all in the past. So this is different for this patient. Okay, so the correct answer is D. This patient needs an urgent CT. This is how sometimes subarachnoid hemorrhage can present. The fact that it came out of the blue and it came on in minutes and it's severe and diffuse. Not everyone, sometimes people think, oh, because cranial nerves are normal and they're not got reduced consciousness, that it can't be subarachnoid. That's not the case. Reduced consciousness can often be a very late feature, and sometimes it can be absent, okay, when we see them. So the fact that it's out of the blue, very quickly became very severe, these are the big clues, especially in a young patient who's not had any history of headaches before. You've got to take it seriously. So sudden onset, severe and unusual headache, even if they have no altered consciousness, you need to think about subarachnoid. And we can't make this diagnosis, we can't rule it out just clinically. That's why we need imaging. So things like CT scanning is the main thing, but things like a lumbar puncture will also help. It needs to be dealt with in hospital. Okay, let's move on to the second question. I'll give you a minute to look at this. Okay, let me know what you think. What do you think is the correct answer? A, B, C, D, E. So we've got a teenager. If you look at the description, 8 separate episodes of unilateral headache associated with vomiting, phonophobia, photophobia over a period of several months. And it lasts for several hours. So this is very typical of migraine, right? So that fits in terms of diagnosis. So he's had some paracetamol. That's not helped. Nothing worrying on examination to suggest he needs to be admitted. You can manage it in the community. So how would you manage migraine in a teenager if something like paracetamol hasn't helped? What can we add? I touched on this briefly earlier, so you might have missed it. So we could add a nasal triptan because they're more effective in teenagers than oral triptans. And you could use something like ibuprofen alongside it, or you could use paracetamol, okay? So nasal is better than oral for this age group, 12 to 17. We don't use metoclopramide in this age group because of extrapyramidal symptoms. Why don't we give aspirin to someone under 16? What's the rare but serious complication that you can see if you use aspirin in under 16s? It can be fatal. Anyone? So if you use aspirin in under 16s, there's a risk of Ray's syndrome. I'll type it into the chat in case you want to look it up later. Ray's syndrome. That's why we don't use aspirin in under 16s. Okay, so we can eliminate some of the options because they're not suitable because of their age group, and that's why the right answer is E. So we talked about this earlier, but in terms of diagnosing migraine, in the UK, we use something called BASH, the British Association for the Study of Headache. This is their guideline. So they look at A, B, C, D, E. So i.e., the first thing, we'll look at that. We won't say it's definitely migraine until they've had 5 different attacks. Like the first time someone presents, even if it's very typical of migraine, if they never get it again, it could be something else because the nature of migraine is chronic, recurrent condition. That the headaches last somewhere between 4 hours and 3 days in adults. I've put this asterisk. In children, you can get migraine that lasts half an hour, an hour. And then it will usually be unilateral, except in children. That's why I've put the asterisk. It can be bilateral, but in adults, it'll be unilateral, pulsating, moderate to severe intensity, and even just walking, climbing up the stairs, not really strenuous exercise, just routine activity can make it worse. When they're having the headache, they'll have nausea or vomiting or both, and photophobia, phonophobia or both. And you don't find anything else that allows you to say, okay, it's this condition. It's something else. In terms of managing acute migraine, for adults, we touched on this earlier, that we will use generally a combination of a triptan orally and either paracetamol and NSAID. For 12 to 17-year-olds, first line would be just monotherapy with paracetamol or NSAID. If that doesn't work, add in a nasal triptan. And we already talked about adding in antiemetics. Okay, so we talked about briefly medication overuse headache. Let's do a question on that. Okay, A, B, C, D, or E. Type into the chat, please. So it fulfills one of the criteria we talked about, i.e. 15 days a month or more of having headaches. So on top of that, which of these would fit the criteria for medication overuse? So the correct answer is B, using a triptan for 10 days a month or more for 3 months. For these options, it needs to be 15 days a month. That's why they're incorrect. And then here, while it fits the 10 days a month, 2 months isn't long enough to say it's medication overuse. The diagnostic criteria need 3 months. Okay. So remember, they've got to have a pre-existing headache disorder, then they have the headache for at least 15 days a month, and then regular overuse at least 3 months. For triptans, 10 days a month or more. For simple analgesics or NSAIDs, 15 days a month or more.
So overuse means 3 months. We can when we use the treatment for 3 months, then we can call it overuse.
So when they overuse is where for 3 months they're using it for this many days a month or more. So using a triptan for 10 days a month or more, or using simple analgesics for 15 days a month or more for 3 months, then that's medication overuse. The reason it's important to identify this, medication overuse, what happens is the medication, they're using it so much, it actually is causing the receptors to fire and causes the headache. So the management of medication overuse is completely different to how we manage regular headache, right? What you do is you stop all headache medications for 1 month to allow the body to reset. Then you reintroduce, say, the triptan, and you monitor how often they use it. And that can be really difficult because the patient say, I've got a headache, and you're telling me not to use my headache tablets. Okay, but it's because the overuse of the medication is actually causing more headaches. It's causing the receptors to fire. That's why we need to reset that by just stopping medications for a month. So that's why it's important to identify this, because otherwise it can just seem like they keep coming, they're taking their medication, but it's not getting better. It's because the medication is actually making it worse. Okay, so to summarize, look, headaches are really common presentation. And one of the things is that in most cases, it's things that are not that serious and that we can manage in the community. But one of our roles is to rule out less common but serious causes like subarachnoid, like brain tumor, like stroke, like, some of the other things we discussed, giant cell arteritis. And then especially for chronic conditions like migraine, a really big part of getting successful long-term outcomes is to educate the patient of things like, actually, if you use the medication too much, it can actually make your headache worse. Of things like keeping a diary, that some patients might not know that food can cause it, or not getting enough sleep can cause it. So they just take more and more tablets. They're not looking at the underlying trigger. If they know that, then maybe they can try and make changes that will help them have less attacks and have a better quality of life. Okay. Right. Any questions before we wrap up? Sorry, I couldn't hear that. Could you say it again or type it in the chat? So I couldn't hear your question. Feel free to type it in the chat. Anyone else got any other questions? By the way, I saw some really worrying posts about some of the violence happening recently. How are things now in terms of? I saw some people were not seeing patients until their safety is assured. How are things at the moment? I read about
Now
some doctors being attacked.
Now it's not it's now cool. I think all the situation is controlled now in our Bangladesh.
Okay.
And our interim government is doing their work, and it's need time. Just few days doesn't not enough time going. So we wait and see what will happen.
Inshallah. Good. Okay. Well, if I'll hang around for 1 or 2 more minutes if anyone's got any other questions, but if not, we'll wrap up there. If anybody wants to connect with me, feel free. You can find me on LinkedIn or on Facebook. Yeah, so feel free to connect. And inshallah, next time I come to Bangladesh, I hope I'll meet with Dr. Kabir again, and maybe we can have some kind of event, maybe some teaching, some training, some food, inshallah.
Okay, thanks.
Thank you very much for everyone for being engaged, for taking part. I hope it's been helpful. And I will send the slides, the teaching slides. I'll send a copy to Dr. Kabir so he can forward it via the admins. Okay.
Are there any questions? There, Dr. Anwar Farooq.
Dr. Anwar, what's your question about overuse? I'll go back to the slide. That might be helpful. Please, Dr. Anwar, what's your question? You can use your mic or you can chat it, type it in the chat. I'd be happy to answer it. Dr. Anwar, are you still there? Dr. Anwar, did you have a question? How to judge about overuse? Yeah, good question. So the main thing really is to think about I think, being aware that there is such a condition so that it's in your mind. Because sometimes patients come, they're frustrated because they're getting headaches a lot and they can't go to work because it's so bad. And so they're taking more and more medications. And they have no concept that actually overusing the medication can make the headache worse. So for you to have it in mind and really taking a very systematic and detailed history. So, not just how many migraines do you get? Because if someone says, oh, I get 5 migraines a month, you might think, okay, that's not that much. But what if each one lasts 3 days? Well, then that's 15 days. So being very specific in your history. So how many days last month did you actually have a headache? And then how many days last month did you use painkillers? Which type of painkillers did you use? And then, okay, what about the month before? What about, so that you can judge, do they meet the criteria? Because if they're regularly overusing, as I mentioned, that can actually affect how the receptors respond, and it can paradoxically cause the headache, i.e. the medication is causing the pain receptors to trigger, and it's actually making the headache worse. So then we would just tell them to stop all painkillers for 1 month to allow them to reset, and then introduce one at a time. So it's just having that consciousness, and then being really, really careful to take a systematic history to work out exactly how many days a month they have it, and exactly how many days a month they have the medication. Hope that helps. By the way, where is everyone from that's on today? I was born in Jagannathpur, Sunamganj, in Sylhet. So someone's asked about fixed criteria for medicine. Do you mean in terms of prescribing for migraine, or do you mean for medication of use? Because you'd asked about medication of use, Dr. Anwar. For overuse, yes, the main thing is it depends on the class. So they shouldn't be using opioids, they shouldn't be using ergotamines. But sometimes patients will get things like codeine for headache from the pharmacy, right? So that's why, again, we want to know. So if they're using these classes, so either combinations, triptans, or sometimes they buy opioids, then 10 days a month is classed as overuse. Whereas if they're using things like ibuprofen, paracetamol, aspirin, then 15 days a month is needed because it's considered overuse. So again, this is why it's important, not just painkillers, but which painkillers are they using, which tablets are they using for the headache is important to classify overuse. Hope that helps. Okay, great. Well, thank you very much, everyone. I think we'll close it there. I can't see any other questions in the chat. I hope that's been helpful. As I mentioned, I'll send the teaching slides across so that you can have them for review purposes later. Thank you very much. Assalamu alaikum.
Thank you, sir.
You're welcome.